transporter pad.
चल अटेंड कर।
Good evening, everyone. I welcome Dr. Sourabh Dutta sir on behalf of IN Group. We are actually lucky enough to have sir on the topic, which is most of the time quite confusing for us. The sir doesn't need any introduction as such, and we are honored to have him right now as a part of a guest lecture series. And I'm very honored to welcome you, sir, on this platform. Thank you so much, sir, for accepting our request, and thank you for sparing your time uh, in this hour that is at 9 p.m. for the time a different time for me. Thank you so much, sir, for your acceptance of request, sir. Over to you, sir.
Yeah, thank you, Dr. Gunjana. Am I visible? I don't know whether my video is working or not.
Yes, sir. Yes, sir.
It is. Okay, okay. And I'm audible, I'm sure. Yeah, thank you very much for this invitation, and it's a real pleasure to be able to speak to so many young, enthusiastic neonatologists who have also turned up at 9 p.m. It's not just me. So, should I share my slides right away and
Yes.
get going? Yeah.
Yes.
So let's see. Yeah, is my slide visible?
Yes, sir. It's visible, sir.
It's visible.
Yes, sir. It's on the slide share now.
Yep. So, good evening, everybody, and welcome to this session on the pitfalls in the diagnosis and management of neonatal sepsis. So, why talk about neonatal meningitis? What's so special about neonatal meningitis? The first thing is that its prevalence is higher amongst neonates than any other age group. We all know that. Secondly, the long-term consequences are more sinister than sepsis without meningitis. Severe bacterial sepsis itself has certain bad long-term consequences, but it becomes much worse with there is meningitis. Lumbar puncture being an invasive procedure on a vulnerable organ, it is more difficult to investigate meningitis. The ethics committees are usually reluctant to permit repeat lumbar punctures, making research into certain aspects of neonatal meningitis very difficult, and we'll come to that now. And frankly, our collective ignorance about neonatal meningitis is appalling. You'll realize by the time I've finished this talk, there are so many gaps which are still there in our knowledge about neonatal meningitis. So I think it's a good time to focus about this very important infection. So what's going to be the overview of my talk? The first is, okay, so what if we miss a diagnosis of neonatal meningitis? Does it really matter? Number two, are there any neonates at such low risk of meningitis that we can avoid doing a lumbar puncture in them? That means,
Special
can I request everybody to put their microphones off? Third is, how do we interpret CSF findings, which is not as easy as it sounds. Does delayed analysis alter CSF findings? Are there any point of care tests available for CSF glucose and cells? How do we interpret traumatic taps? Traumatic taps are far more common in the neonatal period than any other age group. Does pre-treatment with antibiotics alter the CSF picture? How long does it take for abnormal CSF findings to normalize after giving antibiotics? I'm going to skip the next two, the role of procalcitonin and CSF PCR DNA sequencing. That's more of a research thing. And I'll go to the last one. How long should one treat with antibiotics? Okay. So what if we miss a diagnosis of neonatal meningitis? So there are short-term and long-term outcomes which have been studied. So this was an old study by Smith, very large study in 2008, where they found that in the short term, mortality in neonatal meningitis versus sepsis without meningitis was almost threefold. And this is in the Western world. It was statistically significant. And here is a study by Bedford, very widely quoted, published in the BMJ in 2001, looking at moderate to severe disability in neonatal meningitis due to various organisms. With E. coli, moderate to severe disability was 24%, higher for GBS, and the highest was for other gram-negative bacteria like, Klebsiella and other stuff. Acinetobacter was not so common in those days, but gram-negative meningitis overall has a very bad prognosis. So neonatal meningitis can be disastrous in the long term. Here's another very important study from Canada looking at long-term disabilities, 10-year disabilities. What they did was they took 111 neonatal meningitis versus 113 controls who had no neonatal meningitis. Any kind of severe outcome, neurodevelopmental outcome, 10% versus 0, moderate, 99% versus 1.8, mean IQ levels were lower, sensory neural hearing loss was far higher amongst those with meningitis, hydrocephalus, of course. So, in a nutshell, this is a disease that one cannot afford to miss because of its short-term and long-term consequences. So, if you undertreat, you are going to land up in trouble. Now, in clinical practice, I mean, all of us would have encountered neonates who we work up for sepsis, but at the same time, we feel that, they're not really very sick looking. And the question often arises that are there some neonates amongst those who we are working up for sepsis who are at such low risk of meningitis that an LP can be safely avoided? Would it be possible to have some markers which tell us that, okay, here is a group, a subgroup in whom you don't need to do an LP? As of today, the standard teaching is that all symptomatic or definite early onset sepsis and all late onset sepsis, LP is a standard of care. But is it possible to identify a low risk group in which we can avoid doing an LP? So is LP necessary for evaluating, for instance, late onset sepsis? Now, this is some data derived from well-designed studies. These are all prospective, non-case controlled designs to try and get a sense of what is the prevalence of meningitis in late onset sepsis. So as you can see, these studies are not too old. One of them is our own study, the last one, with reasonably big sample sizes. And this is the prevalence of meningitis. And if you just eyeball these figures, the ballpark figure is somewhere in the range of about 5 to 10%. So amongst all late onset sepsis, about 5 to 10% will end up having meningitis. These are all either culture proven or PCR proven meningitis. So therefore, LP must be performed in all cases of late onset sepsis because it is not possible to predict in advance who will be blood culture positive. So we cannot just restrict it to those who are blood culture positive. And there is a high incidence of meningitis even when there is a negative blood culture. So what we did was we tried to find out whether there's any low risk subgroup amongst those who are undergoing LP in which it can be safely omitted. So this, we had published it in the American Journal of Perinatology in 2020. What we did was we took 300 consecutive lumbar punctures for suspected late onset sepsis or symptomatic early onset sepsis. And we recorded a whole lot of information prospectively on all. So a lot of demographic data, many clinical features. There were 17 clinical signs, a lot of laboratory data, sickness severity scores, whether the sepsis seemed to be localized to a single organ or not. That means, was it just pneumonia versus generalized sepsis? And then we tried to find an association with meningitis. So we found that definite or probable meningitis was associated with 13 of these large number of variables that we had selected, and those are listed here. I'm not going to go over each one of them. You can just, eyeball all of them. So these are 13 variables. Then we said that supposing we find a group which does not have even one of these variables, not a single variable which is associated with meningitis, that would constitute a really very low risk group. And then let's try and see how many of them have possible meningitis amongst them. So 58 subjects out of the 300 did not have a single of the above variables, which we thought was a very low risk subgroup. But even amongst them, 29% had possible meningitis. That means they had CSF glucose, proteins, or cell counts, which were in a range that we could not, safely say that you should not do a lumbar puncture. So we concluded, and you can read up this paper, that there is really, as of today, no subgroup in which you can confidently say that lumbar puncture can be safely avoided. Second question is, how do we interpret CSF findings? And as I said, this is not as easy as it sounds. So let's go over it one by one. This was a systematic review of normal CSF values in neonates. Let's just start off with the normals first. This was published in 2021 in Neonatology. Prior to 2021, age-related normal CSF values had been published. There were plenty of studies, but the trouble with all those studies was that many neonates had received prior antibiotics before the lumbar puncture was done, and there was a concern that that may alter the picture. And number two, because PCR was not so widely available for viruses, viral meningitis had not been excluded in many of these studies. So one could never be sure whether viral meningitis had been included, and that had messed up the whole picture. So Petra Zimmerman in 2021 published this systematic review on 7 studies that included, within quotes, healthy or febrile neonates in whom meningitis had been reliably excluded. So from this systematic review, they excluded studies that had not reported any molecular diagnostics for excluding enterovirus infections. That means they took only studies where the authors said that yes, in every CSF, we did a viral panel to exclude enterovirus infections. They also excluded studies where antibiotics had been administered before the lumbar puncture, where there were CSF shunts in place and CSF collected by intraventricular routes or routes other than lumbar puncture. So what were these 7 studies? It's very interesting. The 2 of these studies were on completely asymptomatic preterms, published way back in 1977 and 1982, and 2 on asymptomatic terms, again, very old studies, 1974, 1975. And it's remarkable that in that era, this was even allowed. I mean, researchers were even allowed to do lumbar punctures on perfectly asymptomatic neonates who had no sign of sepsis. Modern day ethics committees would probably never allow it. All these 4 studies were from Brazil, and they were included in this systematic review. They took one more study on asymptomatic neonates where lumbar punctures had been done basically to exclude toxoplasmosis. And there were 2 studies that evaluated possible meningitis, but in which all cultures and CSF PCR for all viruses were negative. Both these studies were from the US, and so they concluded that although there was, clinical suspicion of possible meningitis had been effectively excluded. So these were basically normal neonates. Now the trouble was that I just need to move to the next slide. Yeah. So from these 7 studies, there were only 4 studies from where the authors could get specific individual values of WBC, neutrophil, protein, and glucose. So we are now just down to just 4 studies on which all this is based. So this is WBC, neutrophil, protein, and glucose divided into preterm and term. And if you look at the sample sizes, 53, 119, 45, 21, they aren't really huge sample sizes. They're very modest numbers. So for each of these, they publish the median, the range, and the 95th centile. The median is not good enough because it is just a central average number. It can't give you a cutoff value. The range, extremes of the range are also not good enough because one single outlier value could completely change the range. There could be one sort of a freak case who has a very high WBC count, but that doesn't reflect the rest of the group. So the 95th centile value seemed to be a reasonable number to look at, that this is the upper limit of being normal. So you can see for WBC in preterm and term, it is 12 and 10, neutrophils 16, 8, protein 210 and 110, glucose, the 5th centile, because lower glucose is what is associated with meningitis, 32. Now, the trouble with having normative data is this, that A value which is above or below the upper limit of normal is not always equivalent to having the disease. And I'm just showing it with a few graphs. Let's focus on the left-hand side of the slide first. Now, the green is, say, normal population, like Zimmerman's populations in the previous slide. If you are lucky, you will have your diseased population completely separated out at a distance from the normal population. The values are so far apart from normal that it becomes easy to distinguish the two. And maybe you have differentials of the disease which overlap with the normal population, but then they're all distinctly away from the disease. So in such a situation, the cutoff should be here to differentiate the disease from differentials and normals. The cutoff for diagnosing the disease cannot be the 95th percentile amongst the normals, because the 95th percentile of the normals simply tells you that 5% of normal people are expected to have values above this cutoff. It doesn't tell you that everyone who has a value above this cutoff is actually diseased. That's the trouble with trying to, have cutoffs based on normal populations. The problem becomes much worse if you look at the right-hand side of the slide for tests like, for example, CRP for sepsis, just an example, where there is a complete overlap between all these curves, where it becomes impossible to decide where a cutoff should be put. Now, let's see where meningitis falls in all this. So there have been a cutoff values for CSF, WBC, and glucose protein, but there's a very wide range of values reported in literature. I've just taken a few popular and widely accepted cutoff values. These usually range between, for WBC, 20 to 25 for term neonates, 25 to 30 for preterms. For glucose, if it's less than 33 to 40 for terms, 23 to 24 for preterms. Proteins, generally, if it's more than 120 to 170 in terms, 150 to 170 in preterms. So within these ranges, most publications have taken their cutoffs for trying to diagnose meningitis. So what we did was, we did a systematic review and meta-analysis. This was a diagnostic test accuracy meta-analysis of CSF, WBC count, glucose, and proteins for the diagnosis of bacterial meningitis in young infants, which we had published in 2023 in AJP. Our reference standard was CSF culture or gram stain or PCR positive. That was our gold standard, and against which we were trying to see how well WBC, protein, and glucose were performing. So out of more than 17,000 records identified, we finally ended up with 16 studies which were included for the quantitative analysis, which are included in the meta-analysis. And this is your familiar risk of bias plot, where you can see that the fair number of green circles showing a low risk of bias, and a few yellows and reds showing moderate, unclear, or high risk of bias. Okay. So this is the result of the meta-analysis of CSF parameters, and I'd like you to focus on this. So let's take WBC first. There were more than 30,000 participants, so a huge sample size. The median specificity was 87%. The pooled sensitivity at this median specificity was 90%. The positive likelihood ratio was 6.1. Negative likelihood ratio 0.11, and the area under the curve, it is possible to calculate something called an area under the curve even in a meta-analysis of diagnostic tests, was 0.89, which is reasonably good. It's anything above 0.9 is supposed to be good, so this is 0.89. Protein, 89% median specificity, almost the same as WBC, almost the same pooled sensitivity. The pooled likelihood ratio was slightly lower. The area under the curve was just a shade less than WBC. Look at glucose, the number of studies and subjects was much less. Median specificity roughly in the same ballpark figure, but the pooled sensitivity was a lot lower for glucose than for the others. And consequently, the area under the ROC curve was also much less than that for WBC and protein. So this is the only meta-analysis of its kind of CSF parameters. So from this, we conclude that CSF, WBC and protein are better than glucose in discriminating meningitis from no meningitis. So in this meta-analysis, what we also did was to calculate the post-test probability of meningitis if you get an abnormal value of a test versus if you get a normal value of a test. And I'll just walk you through this table. So on the extreme left-hand column is pre-test probability. That means before you did your lumbar puncture, what were what kind of probability of meningitis would you slot the patient at? And we took three possible scenarios: 2% probability of meningitis, 5%, 10%. 2% would be maybe your not very sick child, LP just being done to rule out sepsis. 5% your run-of-the-mill sepsis patient. 10% would be a sepsis patient who's really sick and maybe has some neurological signs as well. So here is a CSF result for each of the three: abnormal and normal, abnormal, normal, and you have WBC, protein, and glucose. So if you are doing it with this, where the pretest probability is only 2%, if your WBC is abnormal, then the probability of meningitis rises to about 14% with WBC, 16% if protein is high, 15% if the glucose is low. So the ballpark figure is around 15%. That means if you're just doing in an LP, in a rule out sepsis situation, and it comes abnormal, there's about a 15% chance that you're dealing with meningitis. If it's normal, then you're virtually excluded meningitis. If you're dealing with a patient who has some signs of sepsis, is modestly sick, if any of these are abnormal, look at this: 27, 30, 29. So a roughly 28 to 30% probability of meningitis. 1/3 of them actually have meningitis. And again, if it's normal, there's virtually no chance of it being meningitis. Really sick kid with neurological signs and so on, if these are abnormal, at best, the probability of it being meningitis is somewhere in the region of about 45%, for WBC, protein, glucose. If it's normal, then again, very low chance of it being meningitis. Now, what does this tell us? It tells us that if these parameters are normal, they are excellent for excluding meningitis, because you never cross, about 0 to 1% chance of it being meningitis. But the trouble is, if they are abnormal, the probability is still not very high. Just imagine, in the most sickest neonates, the probability of it being meningitis is still less than 50%. That means we are over treating more than 50% patients, even when the CSF parameters are abnormal in a sick patient. That much is the amount of over treatment of meningitis that is going on. With that sobering thought, let's go to the next question. Does delay in the analysis of CSF samples affect WBC and glucose? It's not an uncommon thing that you've done an LP, the sample is still lying in your NICU. Somebody, a hospital attendant, is going to take it to the laboratory. In the laboratory, it may wait for a little longer before the analysis is actually done. And what impact does this have? And unfortunately, this is something that people don't take into account. Well, we did a study which we had published in 2009 in the archives, where we looked at this effect. So what we did was we took a CSF sample. We took only those who had a raised WBC count, because we needed to have some WBC to begin with. There's no point looking at change in WBC count if it is 0 to start with. So they all had raised CSF pleocytosis. And then from that sample, within half an hour, we checked the WBC count and the glucose. And from the same sample, after 2 hours, we repeated the WBC count and the glucose. And then after 4 hours, we repeated the WBC count and glucose. The blue line is the glucose, which you can see started off with a median value of around 40, and it gradually fell. The red line is the WBC count, which you can see that the median was above 35 to begin with, and then there was a precipitous fall by 2 hours and 4 hours, and similarly with neutrophils. Fortunately, there was a way of being able to find out the true WBC count. That means the 2 hour and the 4 hour values had a predictable relationship. That means the fall was predictable. So you could back calculate what the true WBC must have been if you knew that 2 hours had elapsed or 4 hours had elapsed before you were able to do the test. But what it tells us is that unfortunately, this is not taken into account in clinical practice or in a lot of research studies as to what is the time gap between doing the LP and measuring your WBC and glucose, because there is a fall which will completely change your diagnosis, because you from a cell count which is in the meningitic range you fall to a normal range. A glucose which is in a non-meningitic range can fall into a meningitic range. So if there is a problem with this, can we do any point of care tests for CSF glucose to try and avoid this spurious decline with time? To answer this question, we did a study which was published just last year in September in Journal of Perinatology, in which we measured the CSF glucose by the glucose analyzer which is there in most blood gas machines. Nowadays, most blood gas machines have a glucose analyzer built in, or with a glucometer, the kind that is used for measuring blood glucose, and using the same glucometer strips. So this slide shows scatter plots of 97 neonates with suspected sepsis undergoing lumbar puncture. The left-hand side graph shows the gold standard lab CSF value on the x-axis and the ABG machine CSF glucose on the vertical axis. And the dotted line out here is the line of equivalence. That means it's a 45-degree angle line, which will show that there is a complete agreement between lab and ABG CSF glucose. So you can see that most of the dots here have fallen on the 45-degree line, and the regression line, which is the solid black line, is almost coinciding with the dotted line. This is with ABG glucose. On the right-hand side is the similar thing of lab, the reference standard, versus the glucometer CSF glucose, and you find the picture is a little different here. The dots are not falling on this dotted line. In fact, they're a little away, and this regression line is not coinciding with this line of equivalence between lab and CSF glucose. We further analyzed it by doing what is known as a bland Altman plot, these 97 neonates, where we plot the mean of the CSF lab and ABG glucose. The mean value is plotted against the difference between the two, lab glucose minus ABG glucose. On the right hand side, it is the mean against the lab glucose minus the glucometer glucose. So out here, you can see that overall, there is a bias of minus 2.47 milligrams per deciliter, which basically means that the ABG glucose is slightly overreading the value. That means it's giving slightly higher values than the gold standard lab glucose. So that's why you get that's why this thing of minus 2.47. But one can live with that. It's not such a big difference. But the difference is huge when it comes to glucometer glucose. So if you were to do it with the glucometer glucose, there is a 15 milligram per deciliter difference on an average, which can completely change your diagnosis. So the lesson from this study was that we can use CSF blood gas glucose to measure you can use an arterial blood gas machine to measure CSF glucose, but not glucometer in place of the lab. And this helps to cut down the turnaround time, and you can get the value very quickly. So just remember this. This is something you can actually implement in clinical practice. Second question was, are there any point of care tests for CSF WBC? Can we use, for instance, leukocyte esterase dipsticks? These are used for urine WBC measurement. So what we did was we did this study, which is currently under publication. We took 344 neonates with suspected sepsis suspected with the Neonatal criteria, who are undergoing lumbar puncture. We did a CSF leukocyte and neutrophil count within 30 minutes of performing the lumbar puncture. And we defined CSF leukocytosis a priori as more than 25 cells per microliter and neutrophilia as more than 15 neutrophils per microliter of CSF. Simultaneously, apart from the routine CSF tests, we took 10 microliters of CSF onto a multi-sticks, which was read as nil, trace, moderate, small, moderate, or large. and we defined positive leukocyte esterase a priori as moderate or large. What we found was that the CSF leukocyte esterase values had a very modest or average sort of a correlation with the gold standard CSF WBC count. Don't be misled by the p-values. That just reflects that it was a big sample size. But the coefficients of correlation were not that impressive. The sensitivity was only 63%. Now, for a disease like meningitis, you want a high sensitivity. Specificity was okay. And the area under the curve was 0.77. As I told you, you need areas under the curve at least more than 0.9 for it to have good discriminatory value. So our conclusion really was that leukocyte esterase cannot really be used. It has a modest sensitivity, poor sensitivity, modest correlation, and a modest area under the curve. Now, I had mentioned earlier that traumatic LPs are fairly common in the neonatal period. So what do we do with these traumatic LPs? What kind of correction formula should we use? So this was a landmark study published by Greenberg et al. In the Pediatric Infectious Disease Journal in 2008, where they took traumatic LP to be defined as more than 500 RBCs per microliter. So they had more than 6,000 LPs, of which 40 were traumatic. The median RBCs was fairly high, more than 4,000 RBCs per microliter, and that was the interquartile range. And this is what they found. So they had some patients in whom the CSF status was non-traumatic, it was less than 500, and so they did not need to correct. There were some in whom it was traumatic, where they left it uncorrected and calculated sensitivity specificity. The ones who were traumatic, they tried different formulas. 500 is to 1, 1000 is to 1, etc., etc. You're all familiar with these various correction formulas. And these are the sensitivities and the specificities. Now, what is really interesting about this and which completely changed our approach to traumatic LPs was that the area under the curve for all of them was almost the same, about 0.78 to 0.79. So it seems there was practically no difference whether you corrected or did not correct, and irrespective of the method of correction. That means your ability to discriminate between true meningitis and no meningitis did not change whether you corrected or you did not correct. Okay. Did anyone look at this thing again? Well, here was a study published in 2017 where traumatic LPs were defined as more than 10,000 RBCs cut off. So they had more than 20,000 LPs, of which 14 were considered to be traumatic. The percentage has dropped here because the cutoff threshold for diagnosing had gone up. And interestingly, among the traumatic LPs, the median RBCs, it went to, as high as crossing 40,000, So even those kind of patients they took as, if in this study. Similar sort of a table, non-traumatic, traumatic, various formulas used, and exactly the same result. The area under the ROC curve is hardly different. Same story. There's hardly any difference whether one corrects or does not correct. And irrespective of the method of correction, you end up with the same ability to discriminate. So even the UK NICE guidelines now say, don't correct for RBCs and traumatic LPs. What happens is that the more you try to correct, you lose sensitivity and you gain specificity. But for a disease like meningitis, which is so dangerous, where you don't want to miss any case of meningitis, losing sensitivity is not a great idea. So the present day practice seems to be that guideline is that don't bother about correcting for RBCs in a traumatic LP. Just take the WBC count as it is. You will end up over treating some, but that's because you're trying to retain sensitivity at the cost of specificity. Okay. Next question. Does pre-treatment with antibiotics alter the CSF picture? This happens very often because although we may want to do the lumbar puncture as soon as we suspect sepsis, we are unable to do for various practical reasons. One of them could be that the neonate may be unstable, and so you defer the lumbar puncture, or because you want to give the first dose of antibiotics within the golden hour, and there's not enough time to get your act together and do the lumbar puncture. The question is, does it alter the CSF picture? Now, in literature, there are only two studies that I could find where among neonates, the same group underwent a repeat lumbar puncture after starting antibiotics. All other studies are either combinations of neonates, children, adults, elderly, everything all lumped together in a study, so you can't tease out the neonatal data. Or there are studies where two different groups are being compared, one with CSF values before lumbar puncture, a separate group with CSF values CSF values after starting antibiotics. So there are only two in which the same set underwent a repeat lumbar puncture after starting antibiotics. So unfortunately, both are retrospective, not prospectively done. This first one from 2020, just 49 neonates, in which they found the blue bars are the values before antibiotics, the orange ones after antibiotics, that there is a marked decrease in the median WBC count in both possible and proven meningitis, and the culture positivity rate drops from 75% to just 14%. And this is after a median duration of about 5 days of antibiotics. This is a bigger study, 2011, where the findings were a little different. They found that the percentage of abnormal, if you took a threshold, abnormal CSF protein didn't decline very much after giving antibiotics for varied durations up to repeat LP was done within up to 30 days of the last lumbar puncture. So from 85% came down to just 75%. Abnormal CSF glucose, you can see here, abnormal CSF WBC, 79% to 65%. So not a very remarkable decline. It's not that it all just turns normal after giving antibiotics for even up to 30 days. This is a study by Lakshmi Srinivasan from Philadelphia, published in 2012, in which they tried to compare all neonates versus antibiotic unexposed neonates. So this was a prospective study, NICU patients undergoing lumbar puncture. They excluded all these kinds of patients. And here is the data. 72% had received antibiotics at the time of lumbar puncture, so the rest had not received. So they made a comparison between these two. And these were the durations for which they had already been on antibiotics before the lumbar puncture was done. And then they divided this group into preterm and term. And the results are given in the next slide. So just focus on this. So what are we looking at? They were looking at the 95th percentile values of WBC, protein, and glucose. For glucose is the 5th percentile because lower glucose is what is suggestive of meningitis. So everywhere they compared all infants versus those who are antibiotic unexposed. Remember, about 70% were exposed, so the remainder are the unexposed. They found that both in preterms and terms, whether you look at WBC, you look at protein, whether you look at glucose, there's not a huge difference in the 95th centile values of the unexposed versus all the infants put together. So none of these p-values were significant. And so they concluded that short antibiotic duration exposures do not alter the CSF WBC, glucose, or protein. If it doesn't, if short durations doesn't affect, so how much time does it really take for abnormal CSF parameters to normalize after starting antibiotics? So time for abnormal parameters to normalize after starting antibiotics. So among those who initially had an abnormal parameter and whose CSF culture cleared in the repeat LP, that's the kind of group that Greenberg et al. Looked at in 2011. So what they found was as follows. For culture, so you're starting off with all those who are culture positive, The median time to clear the culture was about 4 days with a range of 2 to 7 days. That means if you delay your LP by 4 days or more, there's a more than a 50% chance that you'll end up with a false negative CSF culture. If you take protein, all those who are protein abnormal to begin with, just look at this time on the x-axis. It takes a pretty long time for the protein to normalize. It normalizes very slowly. So these are basically survival curves that are being shown here. Glucose, the proportion who are abnormal glucose also declines slowly, maybe a little faster than protein. WBC count, the x-axis we're looking at, 20 days, 40 days, and so on. So it again takes some time for the WBC to actually normalize. So what does this tell us? That it takes time for parameters to normalize. Protein takes the longest, followed by WBC. Glucose takes a shorter time than protein and WBC. The culture, on the other hand, turns negative very quickly. Within about 7 days, almost 75% of all your cultures will become false negative. And in the initial days, first few days, just like in Srinivasan's study, hardly any change in WBC, protein, and glucose. So what are the implications? The implication is that you can do an LP even after a few doses of antibiotics. You can rely on the WBC, glucose, and protein. You may not be able to rely on on a negative CSF culture because that may turn false negative. Second big implication is that if by chance you do a repeat LP, don't use these parameters to judge improvement because it takes time for these parameters to normalize. Just because they have not normalized, say, after 10 days, 20 days, or even 30 days, it does not mean that meningitis is still going on. Final question. How long should one treat with antibiotics? We've always been taught that it's 21 days. So we did a meta-analysis for the National Neonatology Forum in 2024 in clinical practice guidelines. You'll see it on the NNF website. One of the questions we asked was, what is the duration of antibiotics? And after an extensive literature search, a systematic search of 8 citations shortlisted to assess the full text, only one could be included in systematic review because that is the only randomized control trial which has tried to compare 2 durations of antibiotics.
Sorry to interrupt
Unfortunately,
you, sir.
even this had a high risk of bias.
Sorry
So
to interrupt you,
this,
sir.
yeah,
Sir,
sorry,
your screen has gone, sir. You have to reshare.
screen has gone. Mm,
No, sir, screen visible.
Yeah,
Well,
now.
it is there.
Yeah, yeah.
is
Visible.
there?
Visible.
Okay, all right. So, and this solitary study also had a high risk of bias. And funnily, they compared 10 days versus 14 days of antibiotics, and neither of which are standard durations. Normally one would have thought that at least one of the groups should be 21 days. So anyway, and they had a very small sample size, only 35 per arm. The mortality by day 28 was, all non-significant. So nothing could be concluded from this. So our clinical practice guideline group gave a strong recommendation against the use of any short course of intravenous antibiotics till better data is available. So we are left with this 21-day course, although there is hardly any evidence to back it. So what do we sum up? Number one, there is no low risk subgroup in which it is safe to avoid doing an LP, unfortunately. As of today, we don't know of any such subgroup. We desperately need better tests than CSF, WBC, protein, and glucose. These parameters are better for ruling out meningitis if they are normal than ruling in. And between the three, WBC and protein are better than glucose. If any of these parameters are positive, even in the most sick patients, there is at best about a 48 to 50% chance of it being meningitis. The rest of them are not meningitis. So we are ending up over-treating about 50% or more patients. A delay in the analysis alters the CSF WBC count and the CSF glucose, and that's something that must be kept in mind. There is no advantage of correcting for the presence of RBCs in CSF. Point of care tests can be done for CSF glucose using the ABG machine, but as of today, we don't know of any point of care test for CSF WBC because at least the dipsticks has very modest performance. I have not covered CSF procalcitonin and DNA sequencing in this talk for want of time and because it's more researchy. From a practical point of view, antibiotics rapidly turn the culture sterile within about 4 to 5 days, a maximum 7 days. But WBC, glucose and protein, take a long time to normalize, so they can be relied upon even if you have already given antibiotics for a few days. So if you're unable to do an LP before starting antibiotics, at least try to do it within 3 to 4 days. And if for some reason at a later stage you do an LP, do not rely on the non-resolution of CSF parameters to judge non-response. And till better data is available, continue a 21-day antibiotic regime. So as you can see, it's a very mixed bag. There are some areas in which our understanding has improved, but there are a lot of areas where there are huge gaps in our knowledge and big holes in our understanding. So navigating neonatal meningitis is like sailing through stormy waters, stormy seas, and uncharted waters. Thank you.
Thank you so
I'll
much.
be happy to take any questions.
Yes, sir. There is a huge list of questions out there, so I'll just take it one by one, sir. The first question is,
I'll
should
stop sharing. Just,
yes, sir.
yeah, okay.
The first question that we have, sir, that is, should we repeat CSF after 5 to 7 days, sir, to document negative culture?
No, there is no such standard guideline now that you need to routinely repeat a CSF to document negative culture. Very old guidelines used to have this thing that after 48 to 72 hours, repeat a CSF. So the only indication for repeating a CSF if is the clinical course has not improved the way you had expected it to improve.
Okay. The next we have, sir, when should we repeat an LP after a traumatic LP?
Yeah, so there is no study regarding this. We had tried doing one as a thesis in PGI. We had tried to compare, randomized control trial of repeating at 24 hours, but versus 48 hours. But unfortunately, that all happened during the COVID period. We were not able to recruit enough numbers and we couldn't come up with any answer. I don't know of any other author who has tried to do such a randomized control trial. Maybe one of you can try it.
So the next we have, sir, what is the normal range of RBCs in the CSF of a newborn? When to label it as traumatic?
Yeah, so there are a number of definitions, so there's no consensus on this. The most popular one is more than 500 per microliter. When it crosses about 1,000 per microliter, it just starts getting a faint tinge, what you call visibly traumatic. So 500 is the usual cutoff to call it micro traumatic versus macro traumatic.
Next we have, sir, if CSF becomes sterile by 4 days, why is the need for longer course?
Yeah, I mean, the same logic as for, say, blood sepsis. In blood sepsis, if you were to repeat a culture, it would be sterile within 24 hours with many of the antibiotics, which have a very high log kill. The reason we continue is that even when it disappears from the cerebrospinal fluid, the bacteria can survive within niches inside the central nervous system. Just like in blood, bacteria can survive within organs like the spleen, the liver, the bone marrow, while it disappears from the blood. That's one reason. Secondly, blood culture has a limit to its assay sensitivity. There is only so many bacteria per ml that it can pick up. Anything less than that can't be picked up. So just because it has become sterile doesn't mean that the disease has got cured. So, that's why you need to have these longer durations of antibiotics.
The question we have is, what is biochemical meningitis and the antibiotic of choice?
Well, biochemical meningitis is basically your protein and glucose. So protein being above the upper limit of normal, glucose being below the lower limit of normal. Uh, Antibiotic of choice, obviously, it has to be something which has good CNS penetration. So your aminoglycosides are out. If you're giving a beta-lactam, you have to give about 3 times the usual dose that you would give for sepsis. If you're using third generation cephalosporin or a meropenem, then the dose increase is not really that much. It's almost the same as for regular sepsis. And there are some antibiotics which, of course, have poor CNS penetration. Unfortunately, these days we are seeing a lot of Acinetobacter, which is multi-drug resistant, and then you're left with only colistin, and colistin we know has poor CNS penetration. One drug which is not very often used, but which has very good CNS penetration is actually ciprofloxacin. Ciprofloxacin CNS penetration is very good. So it all depends, of course, on your own unit's profile of antimicrobial resistance as to which combination you would use uh, for treating meningitis.
Next, we have, sir, is a cutoff value of WBC and proteins in a term and a preterm neonate.
Yeah, so as I told you, there are no studies comparing one cutoff versus another cutoff and so on. But using the cutoffs that we normally a lot of people have used in the literature when we did a systematic review. So for WBC, it will be something like around 25 for a term and about 30 for a preterm WBCs. And for protein, it would be maybe approximately 180 or 200 for a preterm and 150 to 170 being the cutoff for term. So these are the cutoff values. But with these so-called popular cutoff values, I've told you that they all have the limitations. Your post-test probability doesn't rise more than 48% probability of having meningitis, even when they're all positive.
Role of piperacillin in meningitis. Inflamed meninges allows piperacillin.
Yeah, I mean, it's like any other, beta-lactam penicillin group antibiotic that in inflamed meningitis, it penetrates, in uninflamed, it goes down. And you sometimes have to, with on these penicillin groups, you have to give about 3 to 4 times the usual dose to be able to achieve the required concentration in the CSF.
Any studies on CSF IL-6?
No, nothing that can be, recommended. Very small studies, methodologically questionable. So you can't really rely on IL-6.
Another one we have is any difference in duration of antibiotic between culture, CSF culture negative meningitis and CSF culture positive meningitis?
No, I'm afraid not. I mean, for culture positive itself, we don't have any. Uh, we don't know whether the 21 days is correct or not. The question of having a comparison between these two is, that's out of the question. There's absolutely no data.
There's another question. Sometimes in a preterm with clinical sepsis, when LP is done, WBCs are either normal or borderline, and protein is much higher even though culture is normal. Should we treat that case as a meningitis?
Oh, that's a very difficult question because, we do face that. Um, the protein is the only one which is very high. Uh, you have to see whether there's any other cause for that. Sometimes dehydration can cause increased protein in the absence of meningitis. Congenital toxoplasmosis can have very high protein. I mean, there's an albumin or cytological dissociation. Because otherwise, protein, its performance, as you saw from the systematic reviews, is almost as good as WBC. There's nothing to really choose between them. In fact, the specificity of protein is slightly higher than WBC. So I guess you have to keep the whole, clinical picture in mind. And if you really have a very high protein, say, so 250 milligrams per deciliter protein, no other explanation, WBC borderline, you would probably be safer off treating it as meningitis. As I told you, the cost of missing a diagnosis or undertreating meningitis is very high. That's what keeps weighing on our minds because long-term outcome really goes down if you have undertreated meningitis.
Another is herpes meningitis with RBCs and CSF. Should we add antiviral because there is because no PCR analysis is available?
Well, I really don't know what one can say if you don't have the facility to do it, because ideally, you should be able to do a herpes DNA PCR, and ideally, the treatment should be based on that. I mean, you can start it empirically, acyclovir, but the continuation should depend on herpes DNA PCR report, because otherwise you'll end up treating excessively a whole lot of patients with herpes. Traumatic LPs are pretty common. in the neonatal period. Now, if every baby who has RBCs in the CSF, you start giving acyclovir, or 30-40% patients will end up getting acyclovir, which is unacceptable.
There is use of CSF lactate and CSF pH.
CSF lactate, there are a few promising studies associated with meningitis, but it somehow hasn't really got into clinical practice. So I don't think I can really, on this forum, recommend using CSF lactate or pH. I mean, there is a physiological reason why lactate should be elevated and pH should be low, because if there are bacteria, they'll be consuming and there'll be some anaerobic glycolysis. But again, it's not a standard of care yet.
A single neutrophil in the CSF should raise the possibility
No,
of
no, 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 not at all. The single neutrophil in CSF is in adults. But in a neonate is perfectly entitled to have a few neutrophils in the CSF. We all know that they have a leaky blood-brain barrier. And you remember Zimmerman's meta-analysis of normal WBCs and counts. So up to about 10 to 12 WBCs, of which about 50% being neutrophils, is a perfectly normal thing in neonates.
So can we give IV antibiotics for the initial few days and then change it to oral, giving 20?
Not really. I don't think you can do that for a disease like meningitis. It's been tried out for sepsis. There was a study published from Europe, I think last year, where they switched to oral and they did it as a non-inferiority trial and showed that it was non-inferior. But nobody's ever done it for meningitis, and it's going to take some courage to do it for meningitis, because you can't afford to have poor bioavailability and poor CNS penetration for the duration when you're giving the oral antibiotics. So where the stakes are so high, I think it's not safe to give oral antibiotics to complete the course. Sometimes we do it when for ventriculitis, because it's such a long course, 4 to 6 weeks, and by the time you've lost all your veins and everything, and the baby is malnourished, you can't give intramuscular either, then maybe the final 2 weeks you end up giving oral, but then that's a risk that you're taking.
In the case of cons meningitis, is 14 days enough?
Mm, Cons many. Well, see, as for if you're asking for evidence, well, there's none. In the Western world, they say for Group B strep meningitis, 14 days is a standard of care, as opposed to gram-negative, where you're supposed to give 21 days. So extrapolating from that, whether common cell bacteria, mild thing like cons causing meningitis, you can give a shorter dose. Probably yes, but there's nothing to back it. Even for the Group B strep 14 days, there's no evidence to actually back it, saying that it should be 14 days. And by the way, cons meningitis is an extremely rare thing. You hardly ever get to see any genuine, most of them are contaminants. The only true cons meningitis you get is when there is a foreign body in situ. That means there is a VP shunt in situ. That's when you get cons meningitis. You don't get to see it otherwise.
Dose of ciprofloxacin for meningitis, highest dose which is safe in neonate.
I don't know the answer to that, honestly. You'll have to check it up.
Is traumatic LP associated with high protein?
Yeah, slightly. There are again correction formulas for that. I don't know how reliable they are. That for every 1,000 RBCs, you bump up the protein by 1. That means you actually minus it to get the corrected protein. Yeah, so it does cause a slight increase in protein, but nothing that will really change your diagnosis, I think.
Effect of concomitant IVH on CSF parameters.
Tough one again. I don't think anyone has systematically been able to ever study that. And it also depends on when the IVH occurred. Was it quite some time back, or it's a very recent IVH? Obviously, it was very, very recent. Then you could even have WBCs in your CSF because of the IVH for the same reason as traumatic. And whether the blood acts as an irritant and causes some amount of chemical meningitis, so a mild inflammation, nobody knows. If the blood has been sitting around for some time, can it become xanthochromic, and can you have a high protein? Again, exactly the timing between all these things, the IVH, the amount of blood that came into the ventricular system because of the IVH and how it affects is a very complex issue. So no, I really don't have any easy answers for that.
And roughly how long it will take for a CSF glucose and a protein to normalize in a case of meningitis,
Yeah,
actually?
so that I think I'd already shown the very limited data. The only data is from Greenberg study of 2011. Those survival curves which I had showed in one of the last few slides. That to normalize it may take many, many weeks. I mean, glucose will normalize faster than protein. Protein may, sometimes take up to even a month to become completely normal.
In a case of ventriculitis, is antibiotic duration of 6 weeks enough and a role of intraventricular antibiotic in the same?
Yeah, I mean, traditionally we have been giving 4 to 6 weeks for ventriculitis. Uh, Again, these are, figures just plucked out of the air. Role of intraventricular antibiotics, there is only one systematic review that tried to look at the duration, and that said that if you give at least 3 days of intraventricular antibiotics, that's the figure they arrived at, based on very sketchy evidence, at least 3 days of intraventricular antibiotics, then your mortality rate reduces significantly compared to not giving any intraventricular antibiotics.
If ciprofloxacin is better choice, if there is a CSF which is showing worsening picture with meropenem and vancomycin with a background of ventriculitis and the CSF culture is negative.
Okay. It's a bit confusing, this question.
It's not clear.
It's not clear, yeah.
Whoever
Okay.
has posted this question can actually unmute and ask this.
Okay.
Another one we have is in suspected early onset sepsis with history of PPROM and histopathologically confirmed chorioamnionitis, but the preterm was asymptomatic except for mild RDS, which settled in 24 hours and the blood culture came out to be as negative. Should we do an LP? Because histopaths showed chorioamnionitis.
No, you should not do an LP. The rates of meningitis are much lower in early onset sepsis than late onset sepsis. And in early onset sepsis, where you're treating just for the presence of risk factors, the baby is not really symptomatic, then there is no indication to do a lumbar puncture. The yield of the CSF is very, very low. So the baby should be having frank symptoms of sepsis or should be blood culture positive in early onset sepsis for a lumbar puncture to be justified. So if you're just treating for risk, do not do a lumbar puncture.
We have when repeat LP doesn't help in resolution of meningitis, then there is no use of repeat LP, or is it mandatory to do it? I think this
No,
question.
no, no, it's not mandatory at all. If the patient has clinically recovered in the way you would expect, then there is absolutely no need to do a repeat LP.
Is there any position to perform LP tried other than conventional position?
By conventional, if you mean a lateral decubitus position, yes, there have been positions which have been tried, and the sitting position, I'm glad you asked this question, the sitting position has been consistently shown to be better than the left lateral position. This sitting position, the destabilization of the neonate, surprisingly, is actually less than in the lateral decubitus position. And those who use it, they actually say that it's easier because the vertebrae, they open up, the intervertebral spaces, they open up in the sitting position. Needs a little bit of there's a slight learning curve to it, but this is something a skill which is worth acquiring. Doing an LP in a sitting position in a neonate.
Shall we do LP in suspected cases of late onset sepsis in babies with IVH?
Yes, of course you should do. There's no contraindication to doing it. Uh, Even if it's completely blood stained, at least you can send a culture and a gram stain. That would still be useful.
Well, should quink needle be universally followed for LP compared to normal needles due to risk of?
I don't know, by that, do we mean should a stillet be used?
Uh, I think
So that you don't take a bit of the epidermis. Okay. I don't know. We have never used it in PGI ever. Whenever I have worked abroad, uh, still it used to be a standard of care. I mean, for exactly this reason. But somehow, I mean, we've never actually seen epidermoid cysts or tumors. Not that we've systematically looked at it. So I don't think the benefit is really worth it.
These are the questions that we had, sir. And then we had Alimelu, ma'am. You are here, ma'am. You were just wanted to say something to the sir. You have written in the chat box as well, ma'am. If you could unmute yourself, if you are still present with us. Thank you so much, sir, for your time. I know it's like bombarding of questions one after the
No problem.
but we at the end we again have one more question, that is what the platelet cutoff for the
Okay. Yeah, I think if there are clinical bleeds, then you should not do a lama puncture with thrombocytopenia. Otherwise, 20,000 like for older kids, I think would be a safe cutoff.
Thank you so much, sir. Thank you so much, sir, for your time and for your talk.
Thank you.
It
Thank
was
you.
very useful
Can I
for
can I just make a little announcement while
yes, sir.
everybody's
Sure, sir.
there?
Yes, sir.
So just to reiterate something which I had already put in the group a few days ago, we are having a workshop on neonatal sepsis on the 8th and 9th of March. It's a single theme workshop. I had already put a flyer on the group. I'll probably circulate it again. So all of you are most welcome to register for the workshop. It will be very useful for DM students, DNB students, and fellowship students. It's primarily targeted towards them. So please do make it a point to register. There'll be a lot of very interesting discussion about sepsis, all aspects about it in the workshop. Thank you.
Thank you, sir. Thank you, sir, for your time. Once again, thank you so much, sir.
You're welcome. Bye-bye.
Good night, sir.
Good night.